problems, as I call them in mechanical ventilation, multiple choice answers, and then we'll take our break, and then Janine and I will come back and do a series of board review questions with you guys. So I'm going to give you 5 cases here, or problems, and with that we'll then move on to the break. So, where'd my button go? There it is. So, number 1. A patient with severe COPD has been placed on a mechanical ventilator in volume assist control for respiratory support with the initial tidal volume at 6 mLs per kilo, a rate of 30. Over the next several hours, however, her PCO2 has climbed from 38 millimeters of mercury to 56 millimeters of mercury, and her ventilator graphics have changed. What is the one thing to change that would help here? So we've got a lady with COPD, and her PCO2 is rising on the ventilator, and she is in volume assist control. Here's the flow, here's the volume, here's the pressure. And as you can see, what's happened is her airway pressures have gone up quite dramatically. So what do we want to do with this? Do we want to increase her rate? Do we want to push the button here? There we go. Do we want to increase? Whoa, gave away the answer. Rats. Sorry about that. Do we want to increase the rate, neuromuscular blockers? You would have gotten that anyway. Pressure assist control, decrease the rate, or add PEEP? You better answer this one real fast, gang. Fingers are too fast here. Somebody push a wrong answer. My God, there are people. Look at that. Wake up. Was that you, Henry? Okay, so what's going on here? So let's look at these graphics. By the way, this is, again, almost assuredly due, in some variation, I think, to be on a board exam. So what we've got here is we've got flow, and the first signal here that we want to be looking at is right there. The expiratory flow has not returned to the baseline. So this suggests that air trapping is building up, and that's very common in patients with COPD, particularly ones who are on a fairly high minute ventilation, as this lady is. We're blowing her PCO2 down to 38, for heaven's sake. She may not have seen that for a while. And as you can see, over time, her pressure builds up. So the classic signs of air trapping building up in volume assist control ventilation. Now, why would her PCO2 rise under these circumstances? And the simple answer is that as you increase intrathoracic pressure in these patients, what happens is you start to squash, literally, pulmonary capillaries, and you turn it into dead space. So you end up wasting ventilation. But this is something you really need to recognize, because a knee-jerk reflex, when you see a rising PCO2, is to turn around and say, let's increase minute ventilation more to blow off that CO2. And under these circumstances, it's only going to make things worse. So PEEP, as I described briefly a little while ago, is determined by 3 factors and 3 factors only: minute ventilation, ID ratio, and mechanics. These 3 are the determinants. To fix intrinsic PEEP, you got to fix one of these things. You have to decrease the minute ventilation. It really doesn't matter whether it's frequency or tidal volume. You want to get the minute ventilation down. You want to shorten the ID ratio, lengthen the expiratory time, and obviously you're trying all the while to improve respiratory system mechanics. Come on. There we go. So the correct answer there is to decrease the rate. That was the one choice that actually reduced minute ventilation. Everything else there either kept things the same or made things worse. And again, I'll reemphasize one more time, you're going to almost assuredly see a question on air trapping on critical care boards. All right, we've touched on this issue a couple of times. Wes touched on it a little bit too. Let's go through it one more time. A massively obese patient has undergone bariatric surgery. He is in the ICU requiring vent support for an aspiration. You've got his tidal volume appropriately at 6 mLs per kilo, but his plateau pressure is high, 37 centimeters of water. PCO2 is a little high, his pH is a little on the high side. An esophageal balloon is placed, and you find that the esophageal pressure at end inspiration is 17 centimeters of water. 17 centimeters of water. What should be done with the tidal volume? What should be done with the tidal volume? So we got a plateau of 37, a tidal volume that's good, An esophageal pressure that's high, just to reference this, if I put an esophageal balloon in you and gave you a tidal volume of 6 mLs per kilo, your esophageal pressure would probably be around 3 or 4, maybe 5 centimeters of water max. pH of 7.28. So should you reduce the tidal volume to reduce the plateau? Should you leave the tidal volume alone? Or should you increase the tidal volume? 3 choices. Decrease, increase, or leave it alone. The Pink Panther? Okay, we got quite an interesting spread there. My personal answer is B. Henry, I don't know how to do this on the scorecard, but C is not an unreasonable answer. The only one I don't like is A. But I'm sorry for those of you who answered C. I'd give you partial credit. But B is the answer I like. So what's going on here? What's going on here? And this gets back to this notion of what does the chest wall do to lung mechanics or respiratory system mechanics. So here's our airway pressure that we're monitoring out here. And here is our alveolar pressure, which is what we're interested in. We're interested in the stretch across that little membrane right there. And again, in patients with relatively compliant chest walls like you or I, the pressure out here in the pleural space with a tidal volume of only 6 mLs per kilo is probably going to be down the neighborhood of 3 or 4 centimeters of water. So that means that the plateau pressure you measure is almost entirely driven by what the lung is doing. But we've got an obese patient here. And this obese patient has a stiff chest wall as a consequence of the obesity, and that's going to add to the plateau pressure. Add to the plateau pressure. And we can do the simple math on this. The plateau pressure, I told you, was 37. The esophageal pressure is 17. So we know the transpulmonary pressure is only 20. Only 20. It's not up near 30, where we consider it to be dangerous. Okay, this is an important point, and again, I wouldn't be surprised to see some variation on this theme on the boards, the effects of the chest wall on the plateau pressure. So in this circumstance, 37 does not represent lung stretch. 37 represents a combination of chest wall stretch and lung stretch. And thus, if we wanted to, the tidal volume could be increased if we're really concerned about this pH of 7.28. I happen to not be worried about a pH of 7.28. Numerous studies have shown that permissive hypercapnia is a very acceptable trade-off, especially at this modest level, to protect the lung. However, if some of you are really nervous about a pH of 7.28, given this transpulmonary pressure of 20, well below our worrisome level of 30, there is some room to increase the tidal volume. My particular bias, as I said, would be to just leave it alone. But again, the take-home message I want you to remember here is that in the presence of a stiff chest wall, the plateau pressure we measure is not just driven by the lung. And we have to take into account the fact that there may be some of this plateau may be reflecting chest wall mechanics. Again, in a patient with normal mechanics, normal chest walls, the effect is very small. But the obese, patients with ascites, et cetera, et cetera, et cetera. Some ventilators actually will put esophageal balloons in. Here's an example of a balloon in the esophagus measuring a pleural pressure of 30. The airway pressure is 39. And if you really can't subtract 39 from 30, this ventilator will do it for you and tells you that the transpulmonary pressure is only 9. Okay. This gets back to a question I was asked right at the very beginning. Case number 3. A COPD patient is having trouble triggering the ventilator. What should be done? Now here are graphics. Flow, volume, airway pressure, and we've got esophageal pressure right here. Do we sedate this patient? Do we lengthen the I time? Do we add 5 of PEEP? Do we add 20 of PEEP? Do we switch to a flow trigger? So we got a COPD patient who clearly is uncomfortable and having trouble triggering the ventilator. And we've got all kinds of answers, except nobody liked mine. So what's going on here? What's going on here? Let's dissect this a little further. So here's the esophageal pressure, and here's the airway pressure. Now, what did I tell you earlier? In a normal person, or at least a person with normal airways, the drop in pleural pressure is transmitted to the circuit pressure almost instantaneously. I even gave you a trivia question. It moves at the speed of sound, which is pretty darn fast. Okay? So this lady, on contrast, notice the effort begins right here, and there is a noticeable delay in the ventilator circuit pressure falling. This is a classic sign of air trapping. And what's happening here is this poor patient has to overcome, notice the baseline pressure in the esophagus is almost 35 centimeters of water. This poor patient has to overcome 35 centimeters of water here before the airway pressure, which is 0, starts to drop. This is an incredible load on the respiratory muscles. It's no wonder this patient is dyspneic and uncomfortable. Here she actually is able to trigger the ventilator. There are circumstances where they just don't pull hard enough and the ventilator doesn't respond at all. If you don't have an esophageal balloon, this can still be detected clinically. And what you do is you put your left hand on the patient's chest and your eyeball on the ventilator. And what you will find is you will feel effort. And you will notice the ventilator either won't respond at all or it responds very slowly. You can feel a noticeable delay before the airway pressure graphic changes and the ventilator fires. Remember the first time I saw this a number of years ago, I thought, what a crummy ventilator. But it wasn't the ventilator's fault at all. It's the fact that this poor individual had all this trapped pressure that had to be overcome before the ventilator would fire. Leave the answers up there for just a minute, if you would, please. So how do you fix this? Well, you try to get rid of the air trapping. We already discussed that. Lower the minute ventilation, shorten the I time, lengthen the E time, improve mechanics, etc. But in the meantime, another trick you can do is to add PEEP. Add PEEP to the circuit. What does that do? It doesn't get rid of the trapped pressure in the lung. That pressure is there. What it does is it makes circuit pressure and alveolar pressure much closer to each other. So you don't want to add more than what's in the lung, but you'd like to get close to it. Okay? And what does that do? If the pressures are now closer to each other, now the patient's effort has to be much less to change the circuit pressure. So the correct answer here is to add PEEP, but the correct answer is to add 20 of PEEP because this poor individual has got almost 35 of PEEP trapped inside her lung. Now look what happens when I added 20 centimeters of PEEP. And this is a real patient. Notice the baseline pressure in the lung or in the pleural space doesn't change. That's because what we've added is less than what is down inside the alveolus. But we've made circuit pressure, which is now up to 20, closer to alveolar pressure, and now this patient has a much easier time to trigger the ventilator. So adding PEEP is a good idea. Sedating is not going to help this problem. It's just going to slow unless maybe it slowed minute ventilation down. Lengthening I time is the wrong direction. A flow trigger is going to have exactly the same problem. Exactly the same problem. The continuous flow in the ventilator circuit will not change until the patient has overcome the intrinsic PEEP. So a flow trigger has the same problem. Again, the correct answers would be B or C and D, but D is better because it's closer to what's actually down in the lung. Now, many of you are saying, well, what if I don't have an esophageal balloon? And I realize most of you don't. In fact, I don't do this with esophageal balloons all the time either. But again, you go back to the basic monitoring I described. You put your hand on the chest and your eyeball on the ventilator, and you start dialing up the PEEP. You add 3 or 4 centimeters of water, and you watch what happens. 5, 6, 7, 8. If you're doing the right thing, The patient will start to trigger the ventilator easier. The breathing frequency may actually go up. And the reason it goes up is because you're capturing more patient efforts. Sometimes people do this, and the breathing frequency goes from 12 to 20, and people say, oh my God, the patient's tachypneic, I've made things worse. You haven't made things worse at all. The patient's underlying drive was 20, and now you're just capturing more of them. So if you're doing the right thing, the patient should become more comfortable. The breathing frequency, as I say, may actually go up. And the other thing you will notice, this patient is in volume assist control. Adding PEEP in volume assist control, if there's no intrinsic PEEP, if I add 5 of PEEP, the peak and the plateau will often go up close to 5, unless you make compliance dramatically better. If I add 10 of PEEP, the plateau will go up 8 or 10 centimeters of water. Notice in this patient, I added 20 centimeters of PEEP, and the peak pressure didn't change at all, or at least very little. That's because I wasn't adding PEEP to the system. I was only adding it to the circuit, and it was just equilibrating or getting closer to the pressure inside the lung, making this patient easier, making it easier to trigger the ventilator. This is an important trick, and again, I wouldn't be surprised if a question that related to triggering difficulties in intrinsic PEEP appears on boards. Come on. There we go. A patient with ARDS is receiving high-frequency ventilation. The relationship between circuit pressure, airway pressure, and alveolar pressures is what? And here are your choices. Here's circuit pressure, here's alveolar pressure. So there's circuit pressure, here's alveolar pressure. Equal here, airway or alveolar pressures are even higher. Dampened but lower, dampened similar mean, dampened higher mean. What is the relationship between circuit pressure and alveolar pressure when using high-frequency ventilation? And the answer is D, I agree. This question is probably not going to appear on the boards, but I like to present it anyway because I think it talks about the physiology of high-frequency ventilation. So if you look at a high-frequency oscillator going at 300, 400 breaths a minute, and you measure pressure in the circuit, it's really jumping all over the place. It makes a lot of noise, and you can see the circuit actually jumping around inside the bed, or jumping around on top of the patient. But if you actually measure pressure in the alveolus, it's considerably dampened. And this is the theoretical advantage to high frequency. You don't have high pressures that may overdistend the lung, and you should have very good maintenance of recruitment. Indeed, one way of thinking about high-frequency ventilation is that it's really CPAP. Put it maybe more specifically, I like to think of it as CPAP with a wiggle. And the wiggle isn't enough to provide convective flow ventilation, but the wiggle is enough to use to invoke different forms of air, of gas movement up and down the tracheobronchial tree. Oxygen does go down, CO2 does come up. So the correct answer is CPAP, or CPAP with a wiggle, and the mean pressure in the alveolus generally is similar, if not identical, to the mean pressure in the circuit. Yes, there are circumstances with various harmonics that come up that might alter that, but for the most part, mean pressure in the alveolus is equal to mean pressure in the circuit, but it's just considerably dampened, and as I say, looks like a wiggling CPAP. Case number 5. A patient is receiving the depicted mode here of mechanical ventilation. The thin arrow represents a weak effort, so this is esophageal pressure, very little effort on the part of the patient, and that translates into very low airway pressures, very low flows, very low volumes and very low flows. The thick arrow represents a very vigorous effort on the part of the patient, which results in a big volume, a big pressure, and a big flow. What is this mode? Proportional assist, volume support, volume assist control, pressure support, or airway pressure release ventilation. And most of you got this correct. This is that mode I very briefly described, proportional assist ventilation. So what is proportional assist ventilation? As I mentioned briefly before, it calculates inspiratory resistance and respiratory system compliance. It monitors flow by the patient, and then it calculates a work of breathing for that flow demand, and then puts a gain on the system. And I used this analogy before. It's like power steering. The patient determines how much of a volume he or she wants. The system simply unloads that effort. And like an automobile driver, the patient must be reliable. Power steering does not guarantee a nice right turn. Power steering only makes it easier for you, the driver, to execute that right turn. And as I say, there's only a single knob really to set. It measures the total work of breathing, and you say, I want to unload 75% of that. I had more stuff here than I thought. There we go. So just to underscore how it looks differently than other modes of support, here is end-tidal CO2, here is airway pressure, and here is volume, with 3 different modes of interactive support. And I want to start over here with volume assist control. So in this experiment, this patient was given CO2 to breathe. And what does that do? That increases his respiratory drive. He wants more gas. In volume assist control, as I showed you before, the volume will not change. The flow will not change. And as a consequence, the patient ends up sucking the airway pressure graphic downward. That's the big disadvantage of volume assist control. It will not respond to patient efforts. Pressure support, you increase the drive. The volume does get bigger, but the pressure is maintained. That's what drives the increase in tidal volume. The bigger drive, the pressure is maintained with pressure support, and the tidal volume gets bigger. With proportional assist, notice you get increases in both pressure and in volume. So it's a little different form of interactive support. There are anecdotes that say it may help synchrony. It makes a lot of theoretical sense. The downside, as I say, there is nothing to guarantee support if the patient's effort diminishes. How are we doing, Joe? Can I do one more? One more. I'll do one more. A patient with ARDS is recovering from hypoxemic respiratory failure. PEEP is 5, FiO2 is 40%, not on pressors and can trigger spontaneous breaths, receiving 14 centimeters of pressure support. An SBT is terminated after 15 minutes because the patient really looks uncomfortable. What do you do now? A failed spontaneous breathing trial. So your choices: return to pressure support and try to wean it down to 7 centimeters of water and then reattempt the spontaneous breathing trial. Return to pressure support of 14, wait 24 hours and repeat the spontaneous breathing trial. In other words, don't adjust the pressure support. Replace pressure support with SIMV and wean to a rate of 2 breaths per minute and then attempt the SBT. Replace pressure support with volume assist control and do spontaneous breathing trials every 8 hours. What do you like best there? Okay, return to pressure support of 14, and that's my favorite answer also. The key point I wanted to make here is that doing the spontaneous breathing trials every 24 hours is the right way to go in this patient. Doing them any more frequently than that has never been shown to be any better than doing it once every 24 hours. The other key point here is there really is no need to change from a simple, comfortable level of support like pressure support of 14. There is no need to try to wean the pressure support. There's no need to switch to another mode. You keep the patient comfortable, you continue the antibiotics, the bronchodilators, whatever else you're doing, and you simply come back the next day. The evidence supporting any other approach really doesn't exist. And I showed you this slide before. Again, the fastest way to get a patient off the ventilator is to do daily spontaneous breathing trials. I don't know whether I have any more or not, but even if I do, we're running out of time here. And I had all kinds of cases here, don't I? Whoa, baby. Anyway, these are all in your syllabus, and they're